Good morning, everyone.
Good morning.
Thank you for being here, and please, I hope you're enjoying breakfast and coffee. We're so pleased to see all of you here today. Today, in the interest of time, I'm just going to jump right in because we have a great panel of speakers for you, and we want to give everybody enough time. Today, we're going to begin to unpack the true impact, all morbidities and mortality issues related to prolonged obstructed labor. And this is familiar to many of you here who've had the opportunity to work in settings where prolonged obstructed labor, lasting for days, is something that you deal with on a regular basis. And for others of you who are in high-income countries where we deal with the form fruste of obstructed labor and call it failure to progress, you can begin to understand what happens when you don't have modern clinical interventions for obstructed labor when it begins to occur. So we have with us here today, well, first I'd like to introduce a supporting organization, BARD Incorporated. We have in the back Derek Neild. A big part of what we'll be talking about today is the role of catheter. What can we do with catheterization to reduce some of the morbidity impact of prolonged and obstructed labor? And BARD, as many of you know, is an international corporation, and Derek has brought many products that you can have a look at. If you want to get up and walk around and move while we're talking, that would be great. He'll also be available afterwards. We also have with us today, I am the project director of Fistula Care Plus, a USAID-funded project that is dedicated to eradicating and treating fistula, and also taking care of women after they have had fistula treatment to reintegrate them into communities. We have also our deputy director, Vandana Tripathi, who is our head of M&E and research. We have Jeff Smith from Japaigo, well known to many of you. We have someone from Nigeria who is a leader in midwifery today. We have Pandora Hartman, who is a midwifery consultant to the project and well known to many of you in ICM. So we're going to start by looking at what some of the evidence is. Prolonged and obstructed labor causes, we've listed them here just to save time, but you can see that the morbidities and mortality extend not just to the mother, but to the baby as well, and involve what in essence requires us to think in a multidisciplinary way, both for the evaluation and for the treatment and for the prevention. Vandana is going to begin by talking about what we have in the evidence base. What are our gaps in evidence and guidelines for prolonged and obstructed labor?
Thanks, Lori. Good morning, everybody. So I will just briefly set the stage, as Lori said, talk a little bit about what do we know on the impact of prolonged and obstructed labor and what is not there, what's missing in terms of guidelines, in terms of knowledge about practices. So this room is full of people who care about this condition, so you know this. It's estimated that 3 to 6% of deliveries are complicated by obstructed labor, and of course higher in those more rural, low-resource settings where malnutrition and cephalopelvic disproportion are more common. It's also estimated that obstructed labor contributes something like 3% to maternal mortality globally, but again, higher in certain regions. Beyond this mortality burden, though, there is a tremendous burden of morbidity. WHO has called obstructed labor the most disabling of maternal conditions. And as Lori said, you know, it can lead to long-term sequelae, including genital fistula, but also things like other forms of incontinence and nerve injuries, resulting in things like foot drop. So we have this picture of morbidity and mortality. And looking just at 49 countries where we know access to C-section is inadequate, it's been estimated that in just 1 year, adequate management of prolonged and obstructed labor could avert over 1 million disability-adjusted life years, could prevent over 59,000 fistulas, and prevent nearly 17,000 maternal deaths. The gravity is clear, and yet there are a lot of gaps and inconsistencies in what's available to midwives and skilled birth attendants managing the condition. First, even the definition. there really is not one clear consensus definition of the condition. When we look at global research papers, we look at professional association guidelines, or we look at WHO documents. The definitions vary from page to page. And even beyond the definitions, simply the terms associated with prolonged and obstructed labor are not consistent. And as Lori talked about, that failure to progress idea, what that means, what unsatisfactory progress means or delay means, completely varies by context. And that has huge implications for identification, referral, management. When we look at what guidance is there for midwives, for skilled birth attendants, we again see inconsistencies and gaps. So a lot of the guidance on managing the condition or assessing its quality sort of ends at delivery and doesn't really give much to the clinician for what to do after. Even something like the criteria-based audit that has been so helpful in looking at how complications are managed sort of says, was a decision taken about route of delivery? Was that decision recorded? And then very, very cursory mention of anything in the postpartum period. And in fact, discussion of postpartum care after obstructed labor is more common in the fistula literature than in the maternal health guidance. And the guidance that does exist can be quite inconsistent. So for example, the WHO Fistula Manual and the Midwifery Training Manual for managing obstructed labor says catheterize for 14 days. On the other hand, the Impact Manual, which is such an important reference for so many of us, says 48 hours. So this creates a rather confusing situation for the practitioner who's caring for a woman. Now, given those inconsistencies, it's important to understand what midwives and SBAs working in those places where this can be such a disabling condition are doing. But there's actually very little information on practices related to obstructed labor. So the Fistula Care Plus project has launched a global survey. All of you have a postcard about it at your table. And this is a survey of low and middle income country skilled birth attendants to understand routine bladder care practices as well as practices during and after prolonged obstructed labor. So we've just completed the pilot phase, and I want to briefly share what we learned during this initial month of piloting. The sample of SBAs who took this survey is a really interesting one. 70% are working in sub-Saharan Africa and some in South Asia. Almost all are midwives. All have at least 2 years of experience, and a third have 10 or more. Nearly all work in hospitals, whether district or sub-district hospitals or academic and referral hospitals. Most are working in urban or peri-urban settings, and most are in public facilities. Nearly all of the respondents work in CMOC or BMOC facilities. So for this group of experienced midwives working in hospitals that manage complications, what do we see? The first thing we see is matching the inconsistency in the guidance. We see a lot of variation in how midwives are defining prolonged and obstructed labor. So you can see that for primips, there is a clustering at 12 hours of active labor, and for multips at 8 hours. But there's a lot of spread, too, from really quite a short duration to quite a long duration of definitions of how long you have to be in labor for it to be considered prolonged or obstructed. And this variation extends to the other criteria. So this tells us what criteria midwives use to say this is a case of prolonged or obstructed labor. Some are nearly universal, as you might expect, like no advance of the presenting part despite strong uterine contractions. But for other criteria, there's quite a lot of variation in whether midwives consider these to be relevant to defining the condition. When we look at care after prolonged and obstructed labor, 2/3 of the midwives actually say, yes, we always catheterize after prolonged and obstructed labor. Only 1/3, though, could say, give a specific reason to, a specific benefit, with the 3 noted by more than a few midwives being, of course, fistula prevention, prevention of bladder injury, and the ability to monitor urinary output. But again, where you see a lot of variation is in the range, the duration of catheterization, with minimums as little as 1 day or as high as 7 days, and maximums as little as 1 day and as high as 30 days. A huge range here. When we think about why midwives feel that they can or can't do catheterization after obstructed labor, infection is by far the most commonly stated risk. This is what people are worried about. Other risks that midwives report include fear of injuring the bladder during insertion, lack of capacity to monitor the woman appropriately, and of course the impact of an increased hospital stay after an already long experience of care. In terms of the enabling environment or the context, less than half of the midwives say that their facility has a protocol for catheterization after obstructed labor. And less than half say that they always or generally have the supplies they need to catheterize. So there are challenges in that enabling environment. But as I said at the beginning, this is our pilot sample of midwives in pretty much BMOC and CMOC facilities, mostly in Africa, mostly in hospitals that are urban or peri-urban. We need to expand the knowledge base a lot more beyond this sample. And so I would ask that you take the survey. If you are an SBA who works in a lower middle income country, share it with your friends. It's online in English and in French. And hopefully we can continue to better understand what midwives are actually doing and the support they need to do more. Thank you very much.
Thank you, Vandana. You know, we think about obstructed labor and the impact of it, and it typically falls into two categories, one being the partograph and all the challenges of implementing the partograph, and the second being that obstructed labor can cause fistula. And arguably, fistula has been singled out as the most important or the most impactful of all of the morbidities that a woman who survives obstructed labor may experience. But we also need to think about all of the other things that the woman is dealing with, as well as her baby. Back to the bladder. Bladder care is crucial during labor, especially a long labor. And we've all seen the instance where we think maybe the labor's not progressing. We put in a catheter, a liter and a half, it comes out, and the baby comes right down, and what have you. And there's also protocols in much of sub-Saharan Africa, in some countries, to use catheters routinely during and even extending after the delivery. So we're going to bring up Pandora Hartman, who's well known to many of you. She's one of the mature midwife leaders. She is in charge of the Rwanda Young Midwives, and she's going to talk to us a bit today about agency, catheters, obstructed labor, and how all this fits together.
Good morning. Everyone's caffeinated enough for this? See, why they like us to come on the other end after you set the stage is because, what do we think? What do we as midwives do? What do we see at the field level? Because when you think about fistula, we're familiar with what it is, so I'm not going to repeat definitions, but we hear about it from a surgical perspective, right? Isn't that what you usually hear? All these repairs, we hear about the camps, we hear about the big campaigns. And okay, so maybe it's a good thing, because we do get some cures out of it, but it's so much physician-run that the role of nursing and midwifery is post-op, yeah? Relative awareness, but the reality is that it's expensive. You need the trained surgeons, and that there are these huge case backlogs. Nigeria, which is our feature country for this, they estimate thousands and thousands of backlogs, and they say 12 to 20,000 new cases a year. Nigeria bearing one of the biggest burdens of both the maternal mortality and the fistula coming together. But we're only repairing about 6,000 a year in that country. But we're getting 20. Is this surgery thing working out? Probably not, huh? When we look at that. So the stories live. Hawa Halima is 14. She lives in a small village and is the only girl of 8 children. She's a girl. It doesn't matter. So let's send the boys on to school. She stays home to take care of the family. When she was 13, she got married. She got married because this was going to bring a better life to the family, and it was one of Dad's older friends, so she became 4th wife. She got pregnant, but her mother-in-law said, we got grandbabies here. You don't need antenatal care. And the TBA says, I deliver all the babies in this village anyway. So along we go. Labor starts, the baby doesn't come out. TBA gets angry, goes away. She's young. A day passes, a night passes. A day passes, a night passes. A day passes, a night passes. TBA says maybe bye. And so she goes to the hospital. 3 times she's exhausted. They get her on the moto and take her to the health center. Baby's gone. They don't find anything. She delivers, dead baby. She goes home. She's isolated. She starts to drip. She smells. She's put out of the house. 3 months later, she's dead. As many women, when we look at the mortality factor of fistula, will die. That's a piece that we don't see. That's the fate of many. Or is it? Does it have to be? I am untouchable. I am depressed. No one will love me. Voices of the women. Or is that their fate? Here we see a fate that changed. Same case start, 13 and married. But what do we see? A new outcome. Why? Can you see here? Drink, drip, and dry. And that was nurses and midwives in Katsina that did that and brought that to the family. We all know this. Why is this woman's life changing? That's a picture from a month ago. Her life is changing because of this. We know what they are. Everybody in Fundamentals of Nursing 101 had one of these, didn't they? This is probably the first thing that you learned how to do. Catheterize a patient. You got really excited because it was a procedure on somebody. Right? Highly cost effective because they're dead cheap. Function, prevention, and conservative management. You see, they've been working on fistula for years, but prevention is our game, isn't it, ladies and gentlemen in the room? Prevention and management. The clinical guidelines, it builds upon a skill set that everybody has. So it's not adding something new, is it? Fundamentals of 101. Easy to implement. And we have tools here that are helpful. The very cheap catheter. This is the ESCA-CON guideline. The East Central and South African Colleges of Nursing and Midwifery adopted this manual. But we found that it has not been used because when I went out country-wise, there wasn't a lot of people that actually knew about it. To the Federal Ministry of Health in Nigeria, who, after a 3-year process, has adopted these guidelines and put them into law. Wow, way cool, right? Nursing and midwives can do this. And nursing and midwifery was at the table every step of the way. This is a good lesson because they also invited themselves to the table, even when they weren't asked to be at the table, for the benefit of women and mothers. But they say this is all book stuff. Nobody actually has the books, nobody has the papers. We own Ministries of Health stuff sits in the Ministry of Health a long time and nobody knows it's there. So what happened next? There's argument in the field. Oh, madame, oh, ma, this is new. This is new, and the reality is this is what they say. So it's new, nobody knows. 2006. So we know there's a theory to practice gap in implementation, but 2006 to 2017, And these guidelines from WHO were written to prevent the formation and or the closure of small fistulas that were less than 2 centimeters. 16 to 18 French catheter, some sterile gloves, and a 10 cc balloon of water. That's what you need. Do we all know how to do that in this room already? With that, minimize trauma if you can with a lot of lubricant, and that's all that you need with your generalized aseptic technique. So this is all good. Seems easy to you so far? So what do the guidelines actually say? So we took the WHO guidelines, we took these manuals that we had, and we pulled it together, and Nigeria is saying we're moving forward with it. In fact, we want to help other countries. I actually went into Uganda in February and met with the association. So if you see them, there's some excited midwives here. They knew nothing about it. They saw me and they came running to hug me. We did it. They didn't ask anybody. They just did it. They had wet patients in domiciliary midwifery, the home birth midwives, checking up on patients afterwards, and they did it, and now their patients are dry. So Uganda is like lining up to take what Nigeria has done and move forward. Really. So if you see Mary, she's a president, ask her about that. So they looked at the guidelines. We sat together, and I've highlighted in red here. This is breaking down the guidelines. These are the problems. Partograph. That's been an existing problem for a long time, because the key to the guidelines is identification of obstructed labor, isn't it? Prolonged and/or obstructed labor, partograph. So what seems easy, voiding. Getting them moving in labor to actually void. Do we have it? Is there a bathroom? Problem, action line. Okay? And just because we have guidelines as well, looking to make sure it matches. A great story is that they were saying, we are doing this, we are doing this, we are writing it on the action line. But when we actually pull partographs at the federal level, we didn't find the action line on the partograph. So how does that work, right? But it's nursing and midwifery who starts digging a little bit to find out some of these pieces. High fluid intake. Not Coke, not Fanta, just plain water. And women who survived immediately and/or on presentation. So these are the barriers I think that nursing and midwifery has identified to making it work. What do? Conservative management and treatment, midwifery-based impact. Why does this work for all of us? Because look at this. There's a great algorithm, and we'll make sure that you have copies of it. But what I want to point out is people got worried. There's no labs, there's no extra clinical tests, and there's no antibiotics that are required when we are looking at a woman with an indwelling cat. So it's really, really easy to implement, we think. Right? Don't like no labs, no, we already knew how to do this. This is a great algorithm here that runs through how we diagnose it, and it's a visual piece that is being adapted at every level so that even the community health worker could use a job aid and say, yes, no, is this patient a candidate for this? So when we look at the red flashing partograph, fluid intake, moving, what's going on, these are our specific clinical issues. Because when we go in and you go into your countries and your places to look at this, do I need an order? We had to analyze this whole WHO and protocol differently. Do I need an order? Because there's a lot of places where a midwife would still need an order to put a catheter in. Because we realize too, when people talk about prolonged labor, they're thinking of the in and out catheter that you would do immediately second stage, yeah? And then they're not thinking of keeping the catheter. And we say, oh my God, the baby's out, we're good now, right? Everyone's happy. This feeds into the forgotten postpartum element. And do I need an order? Independent practice, can I do this by myself? What about if she needs some management? Can I put in a speculum? Because the regulations aren't the same everywhere, whether you can use a speculum, whether you can't, whether you need physician oversight. Standing orders. What are the standing orders at facility level, be they local, state, or government for this? Charting. Need I say any more? Charting. The absent partograph. The absent narrative note. Water and supplies. I bring up water as a big issue as well because water. Where's the bathroom? Where is the bathroom physically located? Can she get to the bathroom? Is there a jug of water? Is there water for disinfectant? Clean running water to wash your hands. These are the issues that we have to look at. Does that woman have access to the 5 liters of water per day that is required to make it work? And supplies, the actual catheter itself, 16 to 18. So even though it seems easy, I'm drawing your attention to some of our barriers and challenges that we'd love for you to be able to go home and do for on-the-ground change. So your challenge leaving here today is to look at your protocols and your standing orders. It's easy, it's simple. Co-development of specific protocols for nurse and midwife catheter implementation for prevention and management. And remember, you got to think about all the issues that are going to get you through a 4 to 6 week period, even though the protocols initially say 14 days and then we recheck. speculum, can they do a digital exam, all of these things. And advocacy for large-scale implementation as a standard offering. It's a document that already exists that the educators can take lift, clinicians take lift, and make it work as well. As we talk about this, there's one piece that I would like to show to you, because as we talk about implementation, we want to think about, this is a job aid that is on your desk for each of you to look at and help us with commentary that is a visual to show people and to get through.
We could spend a good half a day talking about how to use catheters. Just to frame it out for everyone, because we're talking about catheters in different ways. Think of it in 3 phases. Intrapartum, if the woman cannot void well, we don't want the bladder to be contributing to the obstructed labor. Immediately postpartum, in low and middle income settings. I know in Ghana they have pretty strict protocols countrywide for how long to leave a catheter in a woman. It's 6 or 7 days to get her out for baby naming immediately after a long labor, according to their established and well-entrenched criteria. And after a prolonged obstructed labor, if the woman is incontinent, we are going to introduce to you here a new protocol that came out from the Federal Ministry of Health of Nigeria that is consistent with the EXA curriculum we spoke of earlier, how to use catheter for non-surgical treatment of obstetric fistula, and how this needs to belong to the community of midwives. And we are thrilled to have with us here today Dr. Ekpuan Esianamo, who is a senior lecturer and professor of midwifery at the University of Calabar in Nigeria. Thank you.
Thank you very much. Good morning, all. Good morning. Yeah, I'm here to speak about what is going on in Nigeria concerning obstetric fistula. This is a document from the Nursing and Midwifery Council of Nigeria. I'm standing in for Mrs. Alheri Yusuf, who is a Director of Education in the Nursing and Midwifery Council. Nigeria, I'm sure many of you have heard a lot about us, is one of the highly populated countries in Nigeria, in fact, the largest. And we have a sad history of having the highest maternal mortality rate in Africa, and even globally, unfortunately. We have a maternal mortality rate of about 576 per 100,000. There's a high magnitude of fistula, obstetric fistula. 40% of the global burden of obstetric fistula is contributed by Nigeria, unfortunately, with a prevalence of about 150,000 existing cases, an incidence of about 12,000 new cases every year. And out of this, the repair capacity is only 50%. As you have seen, 6,000 surgical repairs a year. So this leads us to a backlog of women requiring repair of fistula. The Nursing and Midwifery Council of Nigeria is responsible for regulating the practice of midwifery in Nigeria. It ensures high quality of nursing and midwifery education and practice as well. It participates in all steps leading to formulation of Federal Ministry of Health guidelines, that is the consensus meetings. So our nurses in the Nursing and Midwifery Council participate at the roundtable discussion of policies of healthcare in Nigeria, particularly fistula repair. Guidelines in place now. What next? Bridging the theory to practice gap. Analysis of Nigerian nursing curriculum showed absence of fistula content in the approved curriculum. of the registered nurse, registered midwife, and even the post-basic midwifery education. Participatory pillar workshop to develop dissemination guidelines specifically for Nursing and Midwifery Council. This was held by Nursing and Midwifery Council in collaboration with Federal Ministry of Health, Uretheral Catheterization Guidelines Implementation, leading the way. Pre-service package to educate nurses and midwives integrated directly into the curriculum. Participation in national level fistula training, update of the trainer course for educators and lecturers on this new component of the curriculum in 2017. Lessons learned and learning, because this is a new area this is a renewed emphasis, as it were, to be able to face frontally the problem of fistula in Nigeria. Be part of the process from the beginning. It has been emphasized that we midwives should be part of this process in fistula care from the beginning, develop implementation strategies that are both donor-driven and contain long-term sustainable strategies to be adopted for ownership by countries. Prevention is better achieved when nurses and midwives are in the forefront of development and implementation. Move briskly when called upon. In conclusion, Nursing and Midwifery Council is committed to the national strategic goal of ensuring that obstetric fistula is prevented, ultimately eradicated from Nigeria, and will work with all stakeholders to ensure this goal is realized. Thank you very much.
We have with us here some of the Nigeria guidelines to share with you, and we'll pass them out during the next speaker. So we're bringing to the podium Dr. Jeff Smith, well known to many of you, Vice President of Technical Leadership at JPIGO. And he's going to talk to us about sepsis, because we know that after prolonged obstructed labor, if the woman suffers a mortality as a result of that prolonged obstructed labor, it's usually through the pathway of sepsis.
Thanks, Laurie, and thanks to my colleagues at EngenderHealth and the Fistula Care Plus program. I really congratulate you for adding this additional dimension of the problem, because as Laurie said, there are many challenges that come with obstructed labor, that not only the management of obstructed labor, but a more comprehensive approach to the care for women who suffer from obstructed labor and prolonged labor and the sequelae. And one of the things that is a really important sequelae is the entire dimension of infection. Even if it's not sepsis, which, as Laurie said, can certainly lead to mortality, but the entire dimension of infection is something that we haven't really addressed fully in maternal health in the last 20 years. If we think about the progress that has been made in addressing maternal mortality, in the last 20 years, there's been substantial progress. And I think all of us should be congratulated for contributing to that progress. But we also have to ask ourselves, what are some of the unanswered questions and some of the dimensions that have still not been adequately addressed? If we think about progress in postpartum hemorrhage, there's been a lot. New drugs, new approaches, new devices. The same thing with preeclampsia. Consensus on use of magnesium sulfate, a number of different dimensions about hypertension, etc. But when we think about obstructed labor, when we think about maternal sepsis, we're not making the progress that we need to. There have been some interventions that have been new, some ideas that are new, but we need a substantial amount of innovation and new thinking in this area. And we also have to ask ourselves whether the approaches that we're taking as a global community of encouraging women to come to facilities, encouraging facility-based birth, are actually making the problem a bit worse because of the crowding in facilities. Often women come in, they deliver, and they want to go home. And so some of the dimensions of infection get masked or hidden because those things are not manifest until several days following the discharge. And also, the issue of obstructed labor and the issue of increasing cesarean section rates that are a result of more attention by me and my brothers and sisters in perhaps the obstetrical field, that's increasing the cesarean section rate, and that also leads to additional infection and additional opportunities for fistula and for other maternal complications. So we have to ask ourselves, the approaches that we're taking are good, they're central, but we need to look at the ramifications of those approaches and whether they also add dimensions of increased infection and increased complications in labor. I was on a panel at the FIGO meeting about 1.5 years ago, and two independent colleagues from Rwanda and Uganda, just by chance, presented on that panel and said that the number one cause of maternal mortality in their hospitals now are infection, because they've worked very hard to reduce the rates of postpartum hemorrhage, to reduce the rates of eclampsia, and now they're dealing with higher rates of infection, in part because of increased attendance in facilities. But when we look at infection and we look at how we teach a more comprehensive approach to obstetric care, we know the package that is basic emergency obstetric care, the things listed here, parenteral drugs, simple procedures. And then we add the dimensions of comprehensive emergency obstetric care, the all-important obstetric surgery, cesarean section, anesthesia, blood transfusion. But when we think about progress that needs to be made in maternal mortality reduction, we're going to have to deal with more and more complex cases. So the presentation of these guidelines on fistula and the use of catheterization, those become critically important as we move forward because the cases are going to get more complex. They're not going to be getting easier as we go forward and continue to reduce maternal mortality. But where are we teaching the management of these complex cases? Where is the management of severe postpartum hemorrhage or a woman who has renal failure as a result of preeclampsia or maternal sepsis? Are these things taught when we teach about comprehensive EMOC? Or is there some kind of a new dimension that we need to be thinking about, some kind of intensive care obstetrics, where we're really thinking, or intensive care maternal health, where we're really thinking about the more complex cases? So again, these guidelines are so welcome. The current situation regarding maternal infection is a bit complex. There are policies that talk about the administration of antibiotics in many countries, but those policies don't necessarily have the breadth that they should, nor are they implemented appropriately. There's practice, but when we think about the antibiotics that are being recommended by global guidelines, the antibiotics that are recommended are simple ones: ampicillin, gentamicin, metronidazole, or clindamycin. But if you think about that, that requires 8 intravenous injections in 24 hours. That busy nurse in the postpartum ward who's managing 30 to 40 patients, does she have time to give 8 different intravenous injections in the course of 24 hours? So we need innovation, we need new thinking about antibiotic regimens that are simpler yet effective. And we're also we don't fully understand the etiology. We did a literature review recently looking at the issue of maternal infection, and there's a great divide between the high-income countries and low-income countries. Unfortunately, in low-income countries, when the literature or the opinion of providers is often, why do women get infection? And I don't mean bacteria. What are the practices that lead to infection? And unfortunately, we often blame the woman. We say the women are dirty. They come in, they're not clean. She came in late. Or the infection prevention practices in our facility are not up to standard. Whereas when we look at a lot of the clinical literature and practices in high-income countries, we talk about the real cause of maternal infection is prolonged labor. prolonged rupture of membranes. That is an obstetric emergency. Prolonged labor is an obstetric emergency as much as postpartum hemorrhage or a woman who's fitting, because that leads to all the sequelae that are described here, and it leads to both maternal and newborn infection. So, where are we as a community in looking at infection as a part of moving forward to address maternal mortality? Who's heard of the Surviving Sepsis campaign? I think this room is generally silent. You know why? When the Surviving Sepsis campaign was initiated years ago, who did it include? It included men, it included adults, it included children, it excluded pregnant women. The Surviving Sepsis campaign says nothing about maternal infection, early newborn infection, puerperal sepsis. So we as a community need to rise up. We need to include maternal infection in these global campaigns to survive sepsis. Why shouldn't pregnant women survive sepsis? Absolutely they must, and it's us who are responsible for doing that. So what has been done to do that? Well, we're raising attention. WHO has just recently issued a new statement on maternal infection and maternal and early newborn sepsis. And there's a global campaign that is led by WHO and JPIGO to really raise the issue and get maternal infection into the minds of everyone who's thinking about sepsis, surviving sepsis, new strategies for addressing infection and sepsis. Where does maternal sepsis come from? As we said, there are many different factors. There are maternal factors, there are environmental factors, and there are delivery factors. But we must keep central in our mind what has been discussed here today. Prolonged and obstructed labor is a central pathway to maternal infection and early newborn infection. And as providers who look at that mother-baby dyad and realize that we have two lives in our hands, we must put attention to this, and we must get innovation, better programming, better action in this area. There are many areas where we can improve. We can improve in terms of advocacy. We can improve in terms of better prevention, and the strategies discussed today are central to that. Catheterization is critical because there are many dimensions to infection. The diagnosis needs to be standardized and improved. It's a simple clinical diagnosis: fever, uterine tenderness, foul-smelling discharge. But often those things are not fully appreciated during labor and not acted upon quickly enough. And as I said, we need to simplify the regimen of antibiotics. We can't ask busy nurses in the postpartum ward to manage 8 intravenous injections in the course of 24 hours. As I said, these new statements and information are coming out from WHO and colleagues. New guidelines have come out and recommendations, but these new guidelines that were addressed in 2014 really focused on preventative aspects and didn't focus enough on treatment aspects of maternal infection. So there's a new round of information gathering, and WHO is about to launch GLOSS, the Global Maternal Sepsis Study. That will be a fantastic study, very unique, for 1 week in September in 100 hospitals across the world. All cases of maternal infection are going to be recorded and categorized. And that huge data collection across 100 hospitals in 50 different countries are going to give us a better understanding of the incidence, the etiologic factors, the treatment, and the approaches that we need to improve in order to tackle this. So it's a 1 week data collection, 24 hours a day. Every case of infection is going to be tracked and categorized. And that is going to form a huge database and give us information that we have not yet had. But also, so they're anticipating both high income, middle income, and low income. So I think we'll have a wealth of data. But then also, we're putting the spotlight on maternal infection. In September, there will also be the Global Sepsis Conference, and there will be a half-day online focus on maternal sepsis. So everyone in this room and everyone around the world can participate because it's an entirely online half-day conference on maternal infection on September 12th, and it's organized by WHO and the Global Sepsis Alliance. So all of us need to tune in and begin to raise our awareness and our advocacy for maternal sepsis. One new program that we're doing in Tanzania is looking at this issue of increasing cesarean section, the need for better cesarean section care, and prevention of infection within that, that environment. So we're leveraging, Japaigo leads the large USAID supported maternal health program in Tanzania, but we're leveraging that with some funding from the GE Foundation and from ELMA to dive deeper into the surgical dimensions of maternal care and the infection prevention for cesarean section. So hopefully in a year or so, we'll have some additional learning and lessons that we can share with you. So I want to thank you for not only your attention, but your commitment as you walk out of this room to begin to think more critically about the issue of prolonged labor, the multiple dimensions that are part of prolonged labor, and how together as a community we address that and the dimensions of maternal infection that come with it. Thank you.
Thank you, Jeff. Well, as you can see, we could spend days literally talking about this, and there's a lot of passion, I think, on both sides of the podium. We're going to take a break and please join me in thanking our co-sponsor for this event, BARD, was key, and I want to invite Derek Neild up. He is the product manager for BARD in Canada, to talk about BARD's commitment to improving standards of healthcare across the globe and how we are going to partner with them moving forward, specifically for catheter care related to obstructed labor.
Thank you very much for the introduction. My name is Derek Neild, and I'm the product manager for BARD Canada. Our African colleagues asked me to fill in as representation, and I'm honored to be here today. So thank you for having me. So I've been with the company now for roughly 2 years, and 2 years and a half, I should say. I was originally drawn to this company because of its rich 100-year history in urology. It brought the first folded catheter to market in 1934, and since then it's been providing quality products with the key focus on improving patient care, such as catheter-associated urinary tract infections in Canada, and now fistula management in Africa, Nigeria, and Bangladesh. So I'm honored to be here today on representation of BARD. I learned about this program. I've been doing a lot of research, thank you for the information, and it sounds incredible to me. I wasn't aware how much this condition was impacting the lives of so many women in Africa, and the stats are astounding. So I'm very happy to see that there's been a project in place, and it looks like the progression has been very successful thus far, and I'm very excited to see what happens over the next coming years. It really comes down to the patient first. It's of course, it's a business, but the idea is the business should be striving for a goal, and that overall goal should be surrounding the patient. So I'm excited to hear that BARD has been partnering with the Fistula Care Plus working group, and I'm here to help support in any way I can. I thank you all for having me here today to learn from you, and I look forward to the ever-changing world that each one of you are impacting.
Okay, well, we could literally have several days and work with our pediatric and neurology and orthopedic and pain management and infertility specialist colleagues and talk about the true burden of disease that comes from prolonged obstructed labor. And I think that's the main takeaway for all of you here today. Please help your ministers of health understand the true burden of disease that comes from prolonged obstructed labor. Help them understand that you need better facilities, your ecosystem needs to be improved, you need more colleagues, you need better healthcare worker density, you need everything that you need so that you can prevent these morbidities. Partner with your pediatric colleagues that are dealing with this in person, having all sorts of developmental delays and problems. I don't know, how much time do we have left? I'm a very bad timekeeper. We have 10 minutes for Q&A.
with midwife clinicians, teachers, researcher, and OBGYNs. And in this conference where we are rightly celebrating midwives, I think we should be celebrating our OBGYN partners, particularly Jeff and Lori here, who've worked with midwives and nurses. To get to the protocols, it will be a joint effort to agree that midwives and nurses can initiate. So it is, this kind of working together really is the example for us.
Thank you, Mary Ellen. And a question back there, and then we're going to start having our response.
As regards to use of catheter to prevent obstetric fistula, as well as in the conservative management. Just like my colleague Jemima said, is like the emphasis is more around surgical. So for me, I think we need to strategically position prevention, because if we don't prevent anyway, it's like mopping the floor while the roof is still leaking. For us in Nigeria, for instance, we realized the need for us to infuse prevention of catheter in the mandatory continuing professional development program, and I think is one promising practice that other countries can learn from, because you see, if it is part of the continuing professional development, and because the continuing professional development countries can learn from, because you see, if it is part of the continuing professional development, and because the continuing professional development is tied to licensure renewal, so you get more and more healthcare professionals across board, doctors, OBGYN, bringing this to their awareness. Thank you.
Thank you very much. All right, let's have response. Vandana, why don't you go first, as your answer was very succinct.
Sure. Koki, thank you so much for asking that question. Yes, so far our sample has been primarily from sub-Saharan Africa. Extremely important, but the world includes many other regions. And in South Asia, we know that the contribution of obstructed labor is higher. So the answer is we are going to continue to enlist our friends and colleagues working in the region, but the answer is also everyone in this room. These postcards are here. The survey is online. Help us find the midwives. We are going to continue to enlist our friends and colleagues working in the region, but the answer is also everyone in this room. These postcards are here. The survey is online. Help us find the midwives and other SBAs who are working in South Asia and Southeastern Asia, who can bring us intelligence on exactly what's happening, how it's defined, how it's managed, and what postpartum care looks like. So thank you for drawing our attention to that.
Pandora, can you take on the partograph question?
Sure. They're all kind of related. What's extraordinary that's happening with Nigeria is building upon the UNFPA work and the pre-service piece. By next year, this content will be in the licensing exam. Working starting in February, it's going at an amazing pace, where by the fall, the teachers will be brought together for some educate the tutors, and we're going to put a package together for the teachers. It's quick, it's easy, and integrated at multiple points in the curriculum, so the content is retaught, so that the action with just working on general partograph knowledge and use, but really working with the tutors. And Nigeria is templating and leading really well. So for those of you who are interested, we can talk more about how the council and association are actually getting that done in a 4-month window. Amazing.
Dr. Asianamo, would you like to tell us how things work in Cross River? What is the perspective on obstructed labor, use of catheter, partograph in Cross River?
Yes. Part of the problem we have is that many of these women don't even come back to the health facility to have their babies. So in such a situation, it's difficult to even find them during labor to be able to use the partograph in their care. So what we are doing is intensifying community education. In such a situation, it's difficult to even find them during labor to be able to use the partograph in their care. So what we are doing is intensifying community education to ensure that more of our women return to the health facilities, return to skilled birth attendants to have their babies. Because once we are able to achieve that, the rate of the fistula will reduce, because as they go to traditional birth attendants, they are kept for too long, and by the time they come into us, there's already complication. So we start from the education, and then also we're going to work on the instructions of the Nursing and Midwifery Council of Nigeria to ensure that educators midwife educators are given training to be able developing a model for training registered midwives already to be able to develop their capacity in the care of and prevention of obstetric fistula. So Nigeria is on course, fighting bravely the fistula. And I know that in a short time we'll have a success story published.
I think we will. Thank you for that. Pandora, I'm going to ask you to come up and sum up some of the points that need to be made here in the community of practice.
Perhaps I'll just make a quick comment
Yes.
about the idea of expanding the scope of practice of midwives and nurses to deal with this. I think I agree that sometimes the medical community can stand in the way and call for a more restrictive approach. But I think you can all identify an example in your country or in your practice where a task has been taken on successfully by midwives in the labor unit. It could be an approach, but I think you can all identify an example in your country or in your practice where a task has been taken on successfully by midwives in the labor unit. It could be manual removal of placenta. It could be MVA for retained products of conception, and identify that process and how that was done and use that as an example. A lot of times people talk about the training gap or the evidence gap. And I would just say all of us must become data collectors. All of us must implement a new, whatever new policy it is, and then track the outcomes in order to prove to the skeptical that a midwife can manage this situation. A midwife can insert a catheter on her own decision and her own judgment, as well as a physician can. And track that and use the path that has already been trodden in order
to sign. If you just give us your card, we really would appreciate it. Okay.
And just summing it up from the clinical, when we look at it perspective, the reality is everybody talks about training. Everybody talks about we're going to do this. But the reality is life is a little bit more interactive. So we also have to come up with strategies to make it better. And when we think about this ministry template that was 2000 October last year, yeah? And that'll be in the council examination. So what we come up with clinically is something to make it work. Who knows about Nollywood? Y'all know Nollywood? 2014, we have a brand new teaching tool for fistula that we'd like to show you how we're going to teach this beyond just how to put in a catheter, beyond how to make it work, with the assistance of Stephanie Linus, who is a very famous Nollywood actress. And this is how we start out, giving all the teachers, all the clinicians a tool with a discussion guide with the features to implement catheter care. And y'all know Nollywood? 2014, we have a brand new teaching tool for fistula that we'd like to show you how we're going to teach this beyond just how to put in a catheter, beyond how to make it work, with the assistance of Stephanie Linus, who is a very famous Nollywood actress. And this is how we start out, giving all the teachers, all the clinicians a tool with a discussion guide with the features to implement catheter care. And I'll leave you with the reality.
Ma, I don't want to marry now.
Halima, you are too young to understand. You are young and this is the right time.
I paid a lot of money to have you as my wife.
I am so honored to be receiving this award.
Why do you come here every Thursday?
I guess I'm supposed to be talking to a shrink.
Is there something you need to talk to me about?
It's almost as if she's trying to make up for something. Don't you want to be part of the team?
I'm already part of the team.
Stop!
I don't want to go back there. I don't want to go back there.
And thanks for coming to help in our small hospital.
Push!
I wish I could die.
We can't save every life. We can't keep losing this women.
Doctor can't take it anymore!
Mom, you're a medical doctor. Your duty is to save lives.
But I did not sign a vow of poverty.
Clean her up before the whole house starts smelling.
Our whole household is infected with disease when make it out.
We need new equipment. A lot of people are dying every day here in this hospital.
What issues could be more pressing than this lunatic doctor who will do anything to paint this country back?
Go back to your father. Go and let your family share in this embarrassment.
Leave my
Think about that. Go.
Oh, they can't just do that. Why are they turning the ground?
Halima!
No!
After you have killed your parents, now you want to destroy my home. Are you sick? So go and kill them.
I told you, Dr. Zara, these people can be crazy!
I want to be a girl again. Can you get that for me?
In your 1-hour class, do you think you might remember how to use a catheter a little bit better with these sorts of teaching tools? We got to get at this a different way in order to have success for moms and girls everywhere, addressing barriers, addressing the issues, the intraprofessional challenges, and remember, they may try to bury us, but we're really seeds that grow into trees. Thank you for your attendance.
We have run over time, but we still appear to have the space. I want to thank all of you for being here with us today. And hopefully we can move this forward and maybe at the next ICM conference have something a little more robust related to obstructed labor. Thanks again. Have a good conference.